Mom's over there. Can you come over and get your?
No.
Therapist. Oh, is your therapist?
Yeah,
Okay.
Susan.
So she's in her bed, whether it's hospital, nursing home, wherever it is. She's acute. She's let's just give her a 4-day. She's in the hospital, 4 days post-op. You're coming in to walk with your instructor says, can you go in and get Miss Brenna up and have her walk over to her bedside chair. She did fine for me this morning. Can you get her up to move over to a chair this afternoon?
What did she just have?
Right total hip.
Right total hip. What's your approach?
She had, good question. She had a, can I grab a walker? Somebody got me a walker, please.
You want
Right total hip.
standard or rolling?
She had a posterior approach. The rolling is fine, since we like rolling. It doesn't matter. It doesn't matter.
Good choice.
Another question. So she's weight bearing is tolerated. And so, can you get her up out of bed and have her walk to the chair to sit?
There it is. Let's see. So we don't want 90 degree, no past 60 degrees of flexion?
Primary hip.
On the hip?
Somebody help her.
90.
You tell them what you want.
Poster.
Posterior approach, so we're not going to have internal rotation or flexion past 90 degrees.
Right.
Slider over.
Yeah.
Got that. Okay.
Feet off.
I'm trying to figure out how to get it right off. Hang this leg down. That seems seamless. Can I sit her up?
Well, how else are you gonna get her to a chair?
Right. Yeah.
We're gonna love it.
Because your arms are fine, so you can just get up, but don't get up past like a certain point. Yeah, put your lay on your hands there. Okay. So that's still not past 90? Okay. And then we're gonna wanna help her legs off. Which leg is the
Right.
Right?
Now stop, don't move. So everybody just kind of look what happens to the femur in relation to the tibia when you grab the tibia. So pick up her left leg, right leg again. That way you had your right hand. Yeah, your left hand was away. Your left hand was away. You were like this.
Just pick up the tibia.
You were
I
like
think
this.
she had me here too. She had my femur.
You were like that.
Okay.
Be careful of when you grab the distal extremity and you start to pull away, you're creating a little bit of motion here at the hip joint. So be very careful of that. Rule of thumb is when you move the operated limb, you want to be both hands to support the limb. Okay.
Okay. So we're gonna move over. Gonna keep your leg extended in front of you whenever we bring you down. Have your feet touch the floor. Okay, so come on. Just like they won't follow. Yeah. Alright. Okay, and scoot forward.
So, anybody see what happened? Right.
Oh,
And
I
that's
did,
a
okay.
really common thing. So go back and do it again. And it is, when you're working with family members to help with their significant other or whatever at home too. So go ahead and come on,
Elbows
go ahead,
instead?
come on up, sit up and turn to the side. See, that's the problem, is you don't want to have it up there. So your position should be, that you're gonna be as low as you possibly can the whole time. Go ahead and come on. And you're just kind of going along for the ride. So you're coming straight down at an angle here. And you want her to guide, you're there to support her. You're not pulling her. She's setting the pace and the speed. But go, keep going.
Okay. Oh, alright. That was it? Okay.
Yeah.
So then tuck your foot underneath you. Assuming this is set for your height. It's a cave, so. your leg straight out in front of you. Leans forward, she's gonna, she'll still be okay, right? Yeah, so just scoot out as much as you can and then push up with your tricep. Okay?
No, supposed to push from the bed.
Push up from the bed and stand up. Okay. Alright, good. Walk her, and she's gonna want a touchdown.
We bring us all
Weight
in.
bearing, right?
We bring us all in.
Right.
This is a critical safety element,
Make sure you're walking heel to toe. Make sure you're walking heel to toe.
and you can put some weight on it,
Maybe laterally. Okay. And then back up into the chair.
If she starts to fall, is your hand gonna do her any good there?
Huh? No.
Okay.
I forgot we were going to the chair.
Yeah. It's like, where are you going? Alright. And before you sit down, reach back, but keep this leg out in front of you. Yep. Reach back to your chair.
Good idea for the pillow, whoever did that.
I think it was just
I did it too, that was good. Okay, so come back over to the bed. Back down. Everything was good, be careful with the other, but when she's walking, you have to have a good hand, especially if you haven't done it before. And I'm glad that you volunteered, because when you jump up to volunteer, you get to practice it, and that's what you guys have to do, practice the words that you use. So don't be a knowledgeable patient, and be a patient that does not understand anything that the clinician is saying, so that they start thinking on their feet of what words to use to be able to describe what they want to have you do. So that's important. All right, so what we're gonna do today is I'm gonna get you up on the edge of the bed, so can I help you with that? Okay, go ahead, come on over to the edge, come on over, you sit up for me. So you don't have to really put a whole lot of thought into how you're telling them to do it. Patients usually figure out. If they can't, go back down. If they can't, one of the easy ways too is, I want you to bend your knees a little bit, bend your knees. I want you to just bridge over to the left side. Good. A little bit more, bring your feet over, bridge a little bit more over. Good. Now what you can also have her start to do is, can you now walk your legs towards me? And if they live alone, it's gonna be easier for them to get their legs off the edge of the bed this way. So bring them all the way down, bring them all the way down. Good, and go ahead and come up on the edge of the bed. And that way, when you're teaching them to be independent, they can use the bed, getting into bed to slide back and across, and when they're in bed and they wanna get out of it, is to reposition themselves to be able to sit straight up. So you can teach them tools that they can use. Now we have her up. Right leg out in front, and go ahead and put your hands on the hand that and you can, what you could do is have them put one hand there and one hand on the walker as they go and stand if you need to do that too. I want you to walk over towards the chair. As you get towards the chair, I want you to turn around and have your back to it. You've got to have a good hand grip here. So if she starts to go down, come back like you're gonna fall. She's not gonna go anywhere. I've got her here, I can control her and move her in any direction. Okay, back up, until you put your left leg behind the chair, pick that right foot out in front, reach back with your hands, keep your head slow and slowly lower your body. That way you have her in control the whole time. So 60 degrees is more challenging. So what are you gonna do for a 60-degree knee flexion contract, a 60-degree precaution? Okay, 60 degrees, you have to stay right there. You're gonna be slouched more, get your body
Behind your
forward.
chair.
There you go. And get your knee out in front. So this is now, she's not flexing past, her 60 degrees. So standing up from this position in a low chair, the only thing that you're gonna be allowed to do is have that leg way out there in front of them. Oh, good.
You can use those.
Okay, have their leg way out in front of them to be able to stand. But if you have a really tall person, they should avoid these types of chairs altogether. And all the patients should try to be using arms with armrests on them. So from this position, let's see if Brenna at her height, keeping that knee down, go ahead and sit up for me. You're keeping that leg down all the way forward. That's where that they're gonna have to be able to do it, right? Keeping that knee down lower than the hip. Okay, back in. Do you want?
Just so they can look at them later as
Okay.
guidelines, yeah.
Well, most places that you go will have some type of information on, exercises, precautions, weight bearing status, and all of those things of how to take care of a patient with a joint replacement, so,
You guys can look at those later for your own.
oh, and I got the implants too.
Yeah.
So again, I think they also don't know if these, so they go through how to go up and down stairs and all of those.
Yeah, it's a general.
So your, rehab program for your total hip patient, when you first are starting to work with them, you'll want to teach them basic exercises, things that are going to reduce swelling, improve blood flow. That's going to get you more comfortable. So we're going to start with just basic ankle pumps, but goes up and down, big as possible. Super. Now I want you to do quad sets. Just tighten up your thigh on this leg. When you do quad sets, especially when patients had a total knee replacement, really watch and make sure they're doing a quad set and not a glute set. What are you going to watch for a quad set? Yeah, you're watching for the patella to actually move. If you hold that patella, do a glute set. Do a glute set with no quad set. Do just a glute set.
I'm trying.
Okay, so some folks do a quad set, do a glute set, and think that their quads are tight, and if you can move their patella back and forth, then they are not doing quad sets. So make sure you're watching for that. Now do a quad set. Good, and you can also watch the lines above the patella. You can hold on to the patella and see if it's moving, but be a real taskmaster back about that. Ankle pumps, quad sets, glute sets, squeeze your bottom. Act like you have a dollar bill between the cheeks of your ear, and I'm going to try to pull it out. Don't want to go, don't want to go, and relax. And do it again. Squeeze. Good. Okay, ankle pumps, quad sets, glute sets. The next one that we have them do is a heel slide. So you're going to slide your heel up towards your bottom. You can use a powder board, you can use a towel, you can use anything. They cannot initiate this very well. You might have to initiate it the first time and then tell them you don't have to take it all the way back down, and eventually they can. This also helps the hip to feel less stiff. The next one that we have them do is a short arc quad, and they can progress to a long arc quad. But usually they can't lift their legs and keep it down there. So go ahead and do a heel slide for me. While they're in the heel slide position, I'll get the pillow into place or the bolster and all the way back down. Can you lift your heel off the edge, off the bed, and then back down? So ankle pumps, quad sets, glute sets, heel slides, and short arc quads or terminal knee extension. These are the same set of exercises done with the total knee, or the same set done with the revision hip or revision knee. So they're also done with an ACL. So they're all, this set are all similar with everything that you'll be treating this way. With a basic set of setting exercises. You can also teach your patient heel raise. You can also teach your patient standing hamstring curl. Those are all kind of the basic sets. So, what are the precautions when you're teaching your patient total hip? Avoid what? 90 degrees. Okay, somebody wants to come up and teach her hip precautions. Okay. Go ahead, no, you take it.
So if you're sitting up here, you don't want to lean forward. You want to stay straight and push up from here. Forward and push up.
That seems alright.
We can have a chair with armrests. How's that sound?
So, picture your right hip, so you should sit back down, and show her how you would stand up with your right hip, not flexing past your 90 degrees.
So keep your leg, keep my leg straight. Have one hand on your walker and then on the other hand on a chair. Push up from there.
Yeah,
Come
and
up.
he wasn't even close to that. I mean, I'm not on that side, but you guys, he wasn't close as 90, was he? And patients want to do the same thing, keep their neck, just keep their heel on the ground. It's for balance and also to reduce the compressive force.
You want to avoid marching or bringing up, flexing the hip.
You don't want to stand on.
Well, this is is
Or
a,
it's weight bearing tolerated, so you wanna avoid turning your foot inwards when you're walking, try to keep your toes forward in that position. Or
so if she's walking and she wants to turn to one side or the other, which side should she turn to?
she should turn to the left.
Why?
Because if she turns to the right, she'll be internal. She's gonna be internal rotating.
Everybody got that?
Mhm.
Good, good.
To turn this way.
That's right. And that's the common thing, people that are thinking and they're not paying attention that they're rotating. What'd you say? You have to be careful from that. Or even turning in this direction. Now they're in relative adduction and internal rotation. So I tell folks, always have your toes facing the same direction as your shoulders. So whatever they're doing this. So they're not doing this with my shoulders here and my toes that way. That way they don't have to think about which way do I go. But that's right, if they're gonna turn one way or the other, for that particular patient, you don't want to internally rotate, so you go the opposite way. Very, very good. Precautions she's had now, we're gonna change it to a total knee. What do you wanna do?
Precautions.
Precautions and positions.
Positions, you don't want the knee at 90 because it could, no, you don't want the knee.
Yes, covered that. What else?
130-degree flexion.
Yeah, we went over and over and over that, right? So what do you want to tell the patient not to do?
Not put on her knee.
Do not, right. Why is that? What is that position called?
Open.
Open pack position. That pillow behind the knee, you can use it for the exercise and immediately it goes away. And that's why I try to teach them off the edge of the bed to do long arm quads early so they don't get in the habit of that comfortable position. So, no open pack position, which is 20 to 30 degrees because that's the capsule is loose, it's gonna swell, it's gonna have quad inhibition, it's gonna get stiff and all those things, that's not a good. So besides she's getting ready to go home, what are you gonna tell her what else she needs to do at home?
Exercises?
Well, positions and precautions. Going back to lecture, not to sit in a recliner. And what position should she be in periodically throughout the day?
Sitting.
Sag or that heel prop position. The more often they do this, because patients after a total knee, you want them to get a 0 to 120 degrees range of motion as soon as possible. It used to be 90 degrees by the first week and then 5 to 10, by 5 to 10. Patients are getting 120 by 2 or 3 weeks, so they're getting it a lot faster. However, the problem with extension remains, and that's because they get home and they get comfortable in their recliner, or they think that it's straight enough and it's like this. That's just, I usually tell folks if it's too comfortable, you're probably not doing something right, and unfortunately that's kind of the truth of the matter for a while. It has to be a little uncomfortable. When it is, they can bring it down and keep it bent back on the floor. It's not all the time, they can alternate from here, they can keep it anywhere in this range in here, just not that 20 to 30 degree position.
I have a question. Sorry. What if they're hypermobile? Like, say if you had Debbie, couldn't she just pop into hyperextension?
Yeah, unfortunately, we don't see a lot of that unless the patient has a collagen disease pathology. Most of the times, these patients are so uncomfortable and in pain when they let it drop. They want to just be comfortable for a little while and they just prop it up.
Also, you gotta remember, when you talk about knee replacement,
Yeah.
bless you, they will shave the distal femur and they'll shave the proximal tibia. Then they put their implants there. Then you have these ligaments, you have the ACL and PCL. So those ligaments prevent translating forces from the tibia and the femur. So a lot of times what they'll do is they have a particular type of implant that if the surgeon decides to remove the PCL, the implant is built in such a way where it's not gonna allow that extreme hyperextension that you would normally see. So in my experience, I have not really seen those extreme positions, maybe with a collagen disorder, but otherwise you don't have to worry about that as much.
What about
At least
like a
if-
ligament, like ACL?
Well, these lateral, the medial and lateral collateral ligaments, they keep those in there for this medial lateral stability, okay? But the ACL, they typically get rid of as well, okay? So again, the joint design is constructed in such a way to support that knee joint.
You'll have usually more of the opposite problem, patients saying, well, I didn't have this before surgery.
Oh, yeah.
And because they hurt for a while, they're not able to bend it straight. But when that surgeon, as he was gonna believe in, that surgeon is in there, he makes sure that they are completely straight and that they can flex 130-something degrees. I mean, they make sure they have good motion. It takes a while for the inflammation and the pain, and this kinesia is a good word you all should learn. UIS, kinesia, and it's the body is not functioning as it normally is. It's either due to pain, surgery, injury, any of those things, but it causes the body to have a discoordinated movement pattern. It happened in the shoulder after a shoulder injury, you have dyskinesia. It happened in the knee, it doesn't feel right. So the muscle memory pattern is really important. So that because they haven't flexed past this in 3 or 4 years, but the more times they have it bent back, that's why ideally for a total knee replacement patient, and we're gonna do this in a second, how many times a day they should be working on their knee flexion is 5 to 6 times a day. And it's not 5 or 6 times between 8 a.m. and 5 p.m. It is all throughout the day. Right when they wake up, before they go to bed at night, and 3 others spaced out, because you're trying to replace that previous muscle memory pattern. So I'm gonna have another patient volunteer. Thank you, Ms. Bruno.
With